Hello, and welcome to session 14 of the Cardiometabolic Echo here at the University of Washington. I'm Nicole Earhart, one of the adult endocrinologists at the Diabetes Institute. And today we're pleased to welcome Nayan Arora, who will be talking to us today about practical considerations for cardiometabolic and renal medications. Additionally, we have Yvonne Mark, our clinical pharmacist, who will be talking to us about patient access. We also have some great panelists to lead the discussion and answer your questions. So that includes Allison Bruner, who is our certified diabetes educator here at the University of Washington. We have Paul Chakowski, who is an adult psychiatrist, also with a background in diabetes and diabetes distress. We have Lorena Wright, who's our adult endocrinologist and also the director of the Diabetes Latinx Clinic here at the University of Washington. We have Lumeta Vidovitz, who is our certified social worker who comes to us from our federally funded clinic, CMAR, so a wealth of information. And then we also are happy to welcome Kelly Branch, our adult cardiologist here at the University of Washington, to help us with the case discussion. And then finally, we're excited to have the patient voice again.
My name is Manoj Srivastava. I've had diabetes for 26 years. A cardiovascular disease for 4 years now, and renal disease, chronic kidney disease for 2.5 years. This has been a long haul, and things that I can take away from this as advice to my healthcare team. Number one is engagement. This addresses one of the problems that we have with our current set of healthcare system is availability and scheduling. Engagement, therefore, is very helpful to patients. Second is being the human touch. I mean, we know this is the cliche about doctors having bedside manners, but it is a cliche for a reason. It really helps me keep better track of my disease. It helped me also remain engaged in things that seem to be going on forever. And finally, some of the remedies that are offered for diabetes and kidney disease are stressful, they're painful, and they're hard on the patients. I know it is hard to keep engaged with what's happening to the patient because there's so many of us, but really helps when my doctors acknowledge that there's a human being at the other end.
And thank you so much for those great words. And I think it is very obvious that what we try to do for all our patients is empathy, communication, and individualizing it. And that's why you guys are all attending the Cardiometabolic Echo. And so we can continue to do great work for all our patients. Go ahead, take it away, Nayan, and share your screen and start the didactic.
The title of the talk is "An apple bark a day keeps a nephrologist away." And so that, of course, means we are going to talk about SGLT2 inhibitors, and it's hard not to when it's a renal-focused talk. So I don't have any relevant disclosures. I do consult for George Clinical, though it has no bearing on the talk I'm giving today. These are the objectives that Nicole mentioned. Now, my slides are going to deviate from some of these. I know we have Yvonne and others who are more adept at speaking to access to medications, coverage, et cetera, and you'll hear from them. What I decided to do was, given that this is the last renal focused block or talk, I went through the old talks and pulled out things or focused on things that we haven't really discussed as much. And so that's how I'm going to proceed here. So I always like to start by giving you a bird's eye view of how myself as a nephrologist look at diabetes, right? So I think it can be easy to get caught up in minutia, may be a bad word, but the ins and outs of glycemic control and day-to-day blood sugar control. I generally have the luxury, which many of you may not, of stepping back and really looking at this globally and thinking about it in terms of preventing progression to kidney disease and reducing cardiovascular events, which is a more long-term goal. And the way we do that is the things in black or the black font here, which is blood sugar control, blood pressure management, albuminuria reduction, and then various medications that have recently, well, or relatively recently come on the market. And I really view diabetic kidney disease like cardiologists view heart failure with reduced ejection fraction. We have tools in our armamentarium, and using these tools has really reduced the burden of end-stage kidney disease in our country, right? So for cardiologists, the way they look at heart failure with reduced ejection fraction is 4 pillars. You have your ACE inhibitors or angiotensin receptor blockers, your beta blockers, your mineralocorticoid antagonists, and your SGLT2 inhibitors. When you look at it from the point of view of a nephrologist looking at diabetic kidney disease, you still have these 4 pillars, right? Coupled which overlap. So ACE inhibitors or angiotensin receptor blockers. For type 2 diabetes, we really should be using angiotensin receptor blockers. Really, ACE inhibitors probably should be phased out. SGLT2 inhibitors, and then we replace the middle with GLP-1 agonists and finerenone specifically, although we don't know that that's any better than spironolactone, and we'll probably never have that head-to-head. And, we're probably going to add to this list, right? There's going to be endothelin antagonists and other things that come out. But right now, these are kind of our 4 pillars. What we don't know is should every patient receive all of these? Should we do it in a stepwise fashion? Should we do it as cardiologists do, which start all these medications together? Or is it going to be more patient specific? Right now, I think what we know is that just about any patient with chronic kidney disease and proteinuria, irregardless of diabetes, should be on some sort of RAS inhibitor plus an SGLT2 inhibitor. There's kind of room for more studies for the middle 2. Now, what is important is that we are making a difference, and all of you guys are helping make a difference in patients with diabetes. So this is looking at the incidence of kidney replacement therapy or end-stage kidney disease secondary to diabetes. And you can see that overall things have improved considerably. This goes over an 18-year period. And what I want to highlight here is 2001. And what happened in 2001 is that IDNT and Renal were published. And, I think we all get excited by new shiny medications, I myself included. But what I wanted to spend the very first part of this talk on is giving homage to the original medication. So these are your angiotensin receptor blockers, with a couple of things that I definitely want to point out to the audience at large. So what we're looking at here is the Renal trial, right? So this was published in 2001 in the New England Journal of Medicine. It was a double-blind, multi-center randomized trial of over 1,500 patients, essentially looking at treatment with losartan versus placebo. And in this case, it was 50 to 100 milligrams of losartan a day. Patients had to have type 2 diabetes plus chronic kidney disease. What I want you to focus on is the bottom left graph here. And what I feel is most important, that there was a nearly a 30% risk reduction in the incidence of end-stage kidney disease. And so we tip our hat to the Renal trial. If you go to IDNT, this was published in the same year, also in the New England Journal of Medicine. This one was actually looking at irbesartan versus amlodipine versus placebo. Similar population, so CKD plus diabetes. And again, if you look at the primary endpoint here, which was a composite of the doubling of creatinine, end-stage kidney disease, creatinine greater than 6, or death, irbesartan had a significant reduction, so 20% versus placebo, 23% versus amlodipine. The big thing to point out is that there was no mortality benefit, and that's always been the case in specifically patients with chronic kidney disease, that although ACE inhibitors, in this particular case, angiotensin receptor blockers, are vital medications, they didn't actually show mortality benefit. They did reduce the incidence of end-stage kidney disease. So again, we tip our hat to IDNT. Despite what we know about those medications, we don't do a good job in this country, particularly when you compare them to other countries. So what you're seeing here is the prevalence of RAS inhibitor prescriptions by CKD stage and countries, looking at Brazil, France, Germany, and the United States. And you can see here that we lag behind other countries in prescriptions of RAS inhibitors to patients with CKD, particularly as we get to the lower stages of CKD, CKD 4 and 5. What's even more alarming, this was a survey of patients treated by nephrologists. So this is not even taking into account, all patients. This was specifically those patients who were referred and under the care of a nephrologist. And so what I wanted to spend a few minutes on is letting people know what are the dangers of stopping these medications, right? So I see it a lot that people get to these later stages of chronic kidney disease, stage 4, stage 5, and their angiotensin receptor blocker or ACE inhibitor gets discontinued. So what happens when you do that? Now, I don't have time to go into this with that much detail. This is a separate talk I've given that's a 30-minute talk in and of itself. But this is a representative example of many studies that are out there like this. This one in particular was published 2 years ago in JAMA Internal Medicine. It's a retrospective propensity matched cohort study looking at a Pennsylvania health system over a 14-year period. There was nearly 4,000 patients. What we're going to focus on is the 2,400 that were propensity matched. So you're going to be looking at the right side of your screen. And essentially, they just looked at what happens when you stop versus continue RAS inhibitors within 6 months of participants to CKD 4 or worse. So eGFR less than 30 or worse. They also looked at a subgroup that had a GFR decrease of at least 40% within 1 year. So a relatively rapid loss of GFR within 12 months. What you're looking at here, I'm going to direct you to the right side of the screen, the top right graph. This is survival on your y-axis, time on your x-axis. And long story short, you're looking at discontinuation of your ACE or ARB in the orange. And there was a significant increase, hazard ratio 1.39, so 40% worsening in the probability of death if the ACE inhibitor or ARB was discontinued. It was a very similar result if you had people who had a GFR loss of greater than or equal to 40% within 1 year. So even if you had relatively rapid loss of GFR. We're looking at the same population, now looking at major adverse cardiac events. So again, very similar hazard ratio, nearly a 40% increase in the probability of major adverse cardiac events if you discontinue the ACE inhibitor or ARB. Same thing in the subpopulation that had a rapid loss of glomerular filtration. And then the thing that people are concerned about generally are, well, if I discontinue it, maybe that'll increase my time to dialysis. You remove the hemodynamic effects of the medication on your glomerulus, you improve your GFR. Will that keep them off dialysis longer? And this study, similar to many others, showed no difference between the two groups in terms of incidence of end-stage kidney disease over time. And I think that is acknowledging the fact that we don't have a GFR cutoff for dialysis. It's based on symptoms. What they did find, as you would expect, was there was a higher incidence of hyperkalemia. So you're looking at hyperkalemia here, years on the x-axis here, and in green are the participants who had their ACE inhibitor or ARB continued, and they had about a 35% increased risk of clinically significant hyperkalemia, which is always a concern. But if we look at that further, so we borrow from the heart failure literature because we don't have that literature in the nephrology world, is what happens with the association between hyperkalemia, RAS inhibitors, and heart failure, right? We know heart failure with reduced ejection fraction is also a major indication for RAS inhibitors. This was a European registry, over 9,000 patients. The vast majority had a reduced ejection fraction with a median follow-up time of about a year. What you're looking at here is all-cause mortality on the top, and then cardiovascular mortality on the bottom. And this is potassium levels on the x-axis. So you saw this U-shaped curve where hypokalemia or hyperkalemia was associated with an increased risk of all-cause mortality and also cardiovascular mortality. However, when you adjusted for discontinuation of your ACE inhibitor or ARB, those two events were significantly associated with mortality. Hyperkalemia no longer associated with increased mortality, right? So what that tells me is that hyperkalemia is a risk for RAS inhibitor discontinuation, but not a risk factor for worse outcomes. And so the way I look at this is I try whatever I can to keep them on these medications. It's not always possible. Sometimes our definition of hyperkalemia differs. So So for me, a potassium of 5.3 is normal. I start thinking about it when it gets greater than 5.5. And I have that discussion with the patient. Maybe I can add or increase the diuretic if needed. Some patients are willing to take Lokelma or other potassium binders in order to keep them on the medication once I share data such as this. I will mention that the STOP ACE trial is the only randomized control trial that we're going to have asking this very question. That's going to be published or at least reported at Kidney Week here in a couple of weeks. So we'll have information from a randomized control trial. The other thing to mention is that if you don't have proteinuria there's no benefit from RAS blockers from a kidney standpoint. Heart failure aside, no benefit from a kidney standpoint other than the blood pressure control. In that case, there's no difference between using alternative antihypertensives and RAS blockers, specifically for kidney outcomes if you don't have proteinuria. And that's important as we get to the flozins. So, it's hard to give now a diabetic kidney disease talk without talking about SGLT2 inhibitors, because I wouldn't even say some of the most, I think they're the most powerful cardiorenal medications that we have. And the way I think about it is they just simply have the side effect of lowering blood sugar in some cases. I don't think they're anti-glycemic agents. I think they just have that quote unquote side effect, and predominantly they're there for cardiorenal protection. And so we've had a large number of trials now. I keep having to update this slide with new studies. The most recent one is going to be EMPA Kidney. Again, it's going to be reported at Kidney Week and likely published in a couple of weeks here. But we've had a number of trials both looking at renal outcomes as well as cardiovascular outcomes. And what's important is that this, although RAS inhibitors do not have benefit with non-proteinuric patients, that's not true with SGLT2 inhibitors. SGLT2 inhibitors, despite the fact that most studies had a requisite inclusion criteria of 200 milligrams per gram of albuminuria, some people snuck in through the screening with no proteinuria. And those subgroups, if you look at a meta-analysis, still had the same amount of benefit as patients that had proteinuria. Now, the EMPA Kidney trial is the first one that's looking specifically at non-proteinuric patients with kidney primary outcomes. And so that's, again, we're going to wait to see that just in a couple of weeks here. It is important to note that although the relative risk reduction is the same whether you have proteinuria or not, the absolute risk reduction, as you would have predicted, is much greater with more proteinuria, right? The more proteinuria you have, the more likely you are to progress to end-stage kidney disease, the higher your cardiovascular risk. Those are the patients that are going to benefit the most. But again, relative risk reduction, same across the board. So this is how we progress. So this is, going to be a slide showing the difference between IDNT and renal looking at angiotensin receptor blockers, and in this case, cretins and DAPA kidney looking at SGLT2 inhibitors. And so your dashed line here is placebo. Your solid line is losartan in this case. This would be irbesartan. You see an improvement. So you have eGFR on your y-axis, years on your x-axis. You see separation of the curves pretty nicely. Same thing with losartan. And then when you start adding in SGLT2 inhibitors, you see an even greater improvement in separation of those curves, placebo versus SGLT2 inhibitor. Same thing with DAPA kidney. Now, what's important is that you're seeing flattening of the lines because these patients are on a background of ACE inhibitor or angiotensin receptor blocker. So you're not seeing the drastic reductions like you did in the original trials looking at purely placebo. And so what this is showing you is that you had significant improvement in every single trial across the board, essentially, in terms of end-stage kidney disease or decreasing eGFR. If it wasn't a primary outcome, it was a secondary outcome in these studies. More importantly, arguably, is all-cause mortality. Again, significant improvement in all-cause mortality, essentially across the board when you look at a meta-analysis. And if you compare ACE inhibitors, angiotensin receptor blockers and SGLT2 inhibitors, the biggest difference is number one, this change in all-cause mortality. The composite kidney outcomes, effects on kidney disease and heart failure were pretty similar. What you're gaining with these medications is not only are you synergistically adding to the benefits in kidney and heart failure outcomes, but you're adding that benefit in all-cause mortality. And what's important is that this medication works across all GFRs. And so whether you have a high GFR, low GFR, every time we've tested them, it has shown benefit. And that bar for where you can initiate keeps getting lower and lower. So if you're in the primary care world or you just happen to provide a lot of primary care for your patients, what I love about these meds is, as opposed to a lot of the other things you treat, they're much simpler, right? So when you have a patient with diabetes, you're monitoring hemoglobin A1C, point of care glucoses, you're mixing and matching between oral injectable medications, dealing with side effects. When you have blood pressures, to do it properly, you need home blood pressure monitoring. Lots of times you need ABPM, you're monitoring electrolytes, kidney function with different medications. Cholesterol, you're targeting various values, adjusting between statins sometimes, screening for myalgias, LFTs, all these things you have to do. With SGLT2 inhibitors, you start the medication and you essentially forget about it once a day and they're done. And I think patients generally like that. So what is your threshold right now? Again, this keeps getting lower and lower. When we started, the eGFR threshold was 30. DAPA-CKD brought it down to 25. Emperor reduced brought it down to 20. EMPA-KIDNEY, which was stopped early because of benefit and we're waiting on results to be presented, has come down to 20. And it will likely still go lower. What I point out is the threshold for an actual anti-glycemic effect is around 45. Below an eGFR of 45, you're not really getting much in the way of benefit in terms of their diabetes management. And why that's important is you get the same benefits in terms of cardiovascular and renal protection with the lower doses. So for example, empagliflozin 10 is more than adequate to provide the cardiovascular benefit. And if you're not going to get the glycemic benefit anyway, it reduces side effects by being on the lower dose. The other thing to remember is that right now, the studies all continue these medication to dialysis. If you start a medication at the appropriate GFR, once they fall below that threshold GFR, you don't stop it. You continue it till they're on dialysis. And in fact, if you look at a subgroup of patients in DAPA-CKD who actually continued the medication on dialysis, that group had a 21% relative risk reduction in mortality. And so because of that, there's two different trials, the largest one being the renal life cycle trial, which is actually studying this in dialysis patients who are non-anuric. So this, again, we may see it more and more even in dialysis patients. This is the image I want everyone to burn in their minds. When they start these medications, you are going to see a creatinine bump or an eGFR decline when you start the medication. It's how it works. It's the same as ACE inhibitors or angiotensin receptor blockers. You're changing your glomerular hemodynamics. In this case, you're constricting your afferent arteriole and you're decreasing GFR. That always crosses over at 12 months, okay? And if you look at EMPA-REG, 28% of patients had a greater than 10% drop in eGFR, 0.5% actually had a 30% drop. But again, if you look at 12 months, everything rebounded or stabilized at 12 months. The biggest risk factors are going to be the lower your GFR, the more proteinuria, the more of a dip you're going to have. Concomitant diuretic use. I highlight this because this is the most important thing that I look at when starting these meds. You are at risk for volume depletion. And so I pay attention to their volume status. And I look at concomitant diuretics that they're on, and I usually make adjustments to diuretics if needed, as long as they're not hypervolemic. And so practical advice for this, one is the greater the hyperglycemia you have, the greater the osmotic diuresis. And this is the thing that bothers patients the most. So all studies excluded participants with a hemoglobin A1C greater than 12. So I do the same thing. I do not start it until I get better glycemic control because, again, they're the best medications we have. It's a long-term play. You don't want to turn patients off. What we know now from multiple studies like MPulse and heart failure, et cetera, is that loop diuretics or flozins will potentiate the effect of loop diuretics by about 20%. So what does that mean? If your patient is euvolemic, then you're going to adjust your loop diuretics. I usually just decrease by 50%. If they're hypervolemic, no change. If they happen to be hypovolemic, I just wait until their volume status is improved before starting it. Patients watch TV, they see ads, they're going to ask you about these things. One thing we need to remove from the adverse effects is the risk of bacterial UTIs. This has not been shown ever to be a concern, despite, I understand that there's going to be, biological plausibility given that you're increasing glucose in the urine. However, you look at studies similar to this one, which looked at SGLT2 inhibitors versus DPP4 inhibitors on the top, GLP-1 agonists versus SGLT2 inhibitors on the bottom. You're doing a propensity match trial looking at participants who started both these medications. There was no difference in UTI risk between the two groups. And what we know is that patients with diabetes have a 60% increased risk of UTIs compared to the general population. So any bacterial UTIs that were reported were likely just association, not causation. So I tell my patients there's not an increased risk of bacterial UTIs. However, there is a risk of genital mycotic infections. And so it's about a 2 to 4-fold increased risk, generally easily treated either with topical antifungals. I will prescribe a one-time dose of fluconazole to many people if needed. What's important is it rarely leads to permanent drug cessation. What's important is making sure that patients know and they have a direct line. They call me if they're having any kind of inguinal rashes, itching, dysuria, etc. How about diabetic ketoacidosis? This is also a concern, specifically euglycemic ketoacidosis. you can see that the numbers in the trials as we learned about this and went further were very, very low. DAPA-CKD, for example, is not going to have many, in that case, it was always looking at non-diabetics where the risk is extremely low, but we have done better after the initial trials where this was first seen. And if you look at this and from a population level, so, this was also looking at new prescriptions of SGLT2 inhibitors versus DPP4 inhibitors in the first 180 days of a new prescription. When you adjusted for all variables, there was a hazard ratio of 2.2 for the risk of ketoacidosis for SGLT2 inhibitors compared to DPP4 inhibitors. So this is something you need to know about. What's important is that most of the studies that reported diabetic ketoacidosis, 83% had some kind of precipitating factor. So either they were ill, they were getting a surgery, they were NPO, et cetera. And so we adjust for this. And what I do is, this is the dot phrase that I have that I provide to all my patients when I prescribe these medications is if you're sick, you hold the medicine. If you're going to have a surgery, I hold it for 72 hours prior to NPO status, and, et cetera. And so this has really reduced the adverse effects that I've seen with this. And like I said, I give this out. It's hard to leave my clinic without a prescription for these. And really, I'll see every once in a while some mycotic infections, but that's, really the extent of it. So what I'm going to leave you with is a little bit more practical advice. The job is to fluosinate as many people as possible. These are the best medications to come out of my lifetime, and we need to really utilize them. What's key is they're not new. I hear some people talk about these as new medications because they are newly kind of advertised. They've been around since 2013. We have extensive experience with these. And the reason I titled my talk the way I did is the molecule initially came from apple bark, particularly in the Northwest. I don't know why this can actually resonate with people. I've actually had people more apt to take these once I share that information. And honestly, I'll use whatever tool I have to get this into as many hands as possible. So that's the end of my didactic portion. I don't know if we're moving on to others. I'm also happy to entertain any questions.
Thank you so much, Nayan. Please, in the chat, give us any questions you might have. I'm going to start with, you sort of summarized, especially for the SGLT2 inhibitors, the risks and benefits of it. So I'm going to summarize my quick and dirty, the 30-second spiel that I give to people that hopefully causes them to start it and to continue it. And then I'm going to ask you to do the same thing for phenobarbital, because it's not a medication I use very much. And I'm hoping you can give us the quick and dirty about how to discuss it with the patient. So for my start of my EMPA or DAPA, I will say, so we know the benefits really protect your kidneys and they protect your heart, especially in heart failure. But what are the risks? So there's a really rare risk of something called euglycemic DKA. And what does that mean? It means that when your body develops acid in the body, you get very sick. And usually because the blood sugar is high, it signals the body to produce more insulin, or you give yourself more insulin. And that protects you from becoming more acidotic, or those acid in the body that makes you very sick. However, because with the sodium glucose cotransporters, you're peeing out your blood sugar, you don't actually get that signal of the higher blood sugar. So how do we avoid it, even though it's really rare? Less than 0.1% of the time do people get this. Well, when you're sick is when you're at most risk of developing this very rare complication. So just make sure to hold that medication if you are having sick days. Now, if you're going about your day normally and you only have the sniffles, you don't have to hold it. But if you're having diarrhea, if you're having a cough and fever that's keeping you from home from work or from doing the things you like, hold it until you feel better. And by just saying that, I have not had any cases of euglycemic DKA in the over 10 years I've been prescribing this medication. And then the next thing I say is, well, what are the more common potential side effects? And so I definitely mentioned that you can develop increased risk for yeast infections, but we can treat that and sort of let us know immediately so you don't have to suffer from it. And then also, I do see in my clinical practice rarely an increased risk for urinary tract infections, but it's very uncommon. And like Nayan said, you just tell them anyone with diabetes can develop urinary tract infections as well. And give them the symptoms of it so that then you can start the medication. And sometimes I'll even order a UA and culture just to make them feel better. If they develop any symptoms, they can go and can contact me so that we can start antibiotics early if that occurs. And I do think that really does help the people not have a barrier to starting the medication. So go ahead, Nayan, would you add anything to that? And then also, how would you talk to us about our MRA, the practical considerations of starting it? How do you tell the patient?
Yeah, so no, I don't have anything to add. I think that was very good about the SGLT2 inhibitors. That's similar to the spiel that I give folks. When it comes to mineralocorticoid receptor antagonists, so the practical advice for practitioners, how I use it is it depends if a patient needs more blood pressure control or not, right? If they have refractory or resistant hypertension, I'm more apt to go to spironolactone. If they don't, and I'm just looking for add-on therapy because they have persistent albuminuria or worsening kidney function despite angiotensin receptor blockers and SGLT2 inhibitors, then I'll use finerenone. And the way I talk to patients about this is to let them know that finerenone specifically is a new version of an old medication, right? Because people get turned off often by new medications, right? They're hesitant to have new things. So I make sure that they know this is a new version of an old medication that has been shown to improved kidney health as add-on therapy to what they're already on. And not only kidney health, but potentially cardiovascular benefit. And we kind of talk about that. There's been 2 really large studies, probably the largest we have actually, showing benefit to a once-a-day medication. Now, that being said, I do have a frank discussion with them about the risk for hyperkalemia. This is a very real, despite what the studies have shown. The more we use it, the more hyperkalemia we see. You think about patients with diabetes who are more likely to have type 4 RTAs. If their glycemic control isn't great, they already have hyperkalemia, right? Because they're in a hypoinsulin state, and then they're on concurrent angiotensin receptor blockers. And so I do go through what the risk benefits are. And I have patients that have ended up in ERs or urgent cares because of hyperkalemia. Now I'm adding on Localma or other things. And so, I do make that very clear up front that it requires a lot of monitoring and there's these potential for complications.
Great points there. And I think those really highlight what we need to discuss with our patients when we're increasing the pill burden, but also putting on them potentially really protective medications, especially for their kidneys. There's a question in the chat about, does the level of the albumin drive the dose of the SGLT2 inhibitor, or do you just stop at the moderate dose?
Yeah, so that's a great question. So no, it doesn't. And so you're just going to use your standard dosing. And so that is going to be empagliflozin 10 milligrams, dapagliflozin 10 milligrams. So it's the same once a day, does not change. As far as your ACE inhibitor or angiotensin receptor blocker, you're always wanting to target the maximally tolerated dose. So that's what's been used in every study. You really want to try to max out their ACE or ARB. And really what maximally tolerated means is, the max dose you can get without sacrificing issues of blood pressure or other effects they may have. And that's why I try to only use angiotensin receptor blockers. You eliminate the issues with cough, angioedema, and now that the price of the long-acting ARBs have come down, there's really no reason to be using ACE inhibitors for this particular population.
Great. The dapagliflozin is actually 5 and 10 milligrams, so I think you could use the 5 milligram dose for that one for the dapagliflozin. But
although the studies use 10, so that's why we're kind of stuck with 10. So DAPA, CKD, et cetera, all use 10 milligrams, and so that's the issue with dapagliflozin.
Thank you. I learned something there. So thank you for that information. And then I loved how you talked about cost. And so that's a great transition to Yvonne going on about our access for patients and medications. So go ahead, Yvonne, share your screen and let's hear a little bit more.
Yes, thank you so much, Dr. Arora, for that presentation. So some of the things I'm going to be just going over will be things to hopefully help with when you're in with the patient trying to prescribe a medication and not necessarily knowing what's going to be covered. And that, I think that's a big problem. If you know what kind of insurance the patient has, you can look online to see if there is the insurance drug formulary or a preferred drug list that you could search for. For the Washington Washington state sponsored plans or the Medicaid plans. A lot of the older medications are obviously covered. And as Dr. Arora mentioned, most of the ARBs are covered. A couple that are not would be like telmisartan. Some of them don't cover candesartan, and then azilsartan. So this is some combination medications that are covered by the various Medicaid plans. I just bring this up just to as options to decrease pill burden, and not every combination is covered. And for those combinations that are not covered, generally they will cover them if you prescribe them separately. I was also looking at seeing if some triple combination products are covered. Unfortunately, a lot of them are not. And again, this is something that you can, if you just look online at the preferred drug list, you can find this information. This slide was created by Dr. Wright, and this is really interesting to see that all of the Medicaid plans do cover the SGLT2 inhibitors with the exception of ortugliflozin. That's really great for access. And even some of the SGLT2 inhibitor metformin combinations, some of them are covered as well with metformin. If someone has a commercial insurance through their employer, there are coupons available online to cover the SGLT2, so they can apply online and then bring that information to the pharmacy to help decrease their copay. So that's another possibility for people who have commercial insurance. For finerenone, I was trying to see if I could find prior authorization requirements for the different Medicaid plans. This slide was created by Dr. Wright and does show the criteria that patients need to meet before they will pay for it. I was also able to locate the criteria for Amerigroup, but unfortunately for the other Medicaid plans, it's not published. So that just makes it more difficult that you have to kind of in the middle of the prior authorization process before you find out what the criteria are. And Walmart is another option for inexpensive medications. And for the ARBs, these are the ones that are available for $4 a month. So just something to keep in mind as another option. And patient assistance programs. So for people with limited income who may qualify for these programs, there is quite a bit of paperwork that needs to be filled out by both the prescriber and the patient. And this is outside of their Medicare Part D, their benefits. It doesn't count towards their out-of-pocket costs. It is an annual program, so they do need to apply every year and fill out the paperwork. And the thing about these programs is they're very finicky about the paperwork. So even if you're missing one tiny little bit of information, they will reject the application. And it also requires that the patient might have to include proof of income as part of the qualifications. And some people might need to have like a family member or caregiver kind of help them out because some of them are quite detailed. The medications can be shipped either directly to the person's home or sometimes shipped to the prescriber's office. Some of them have automatic refills. Other ones require you to, or the office to contact the program. So they're all a little bit different, and it does take just a little bit of time to kind of manage all the different intricacies of the programs, but this is a way for the patient to get their medications free of charge. For 340B pharmacies, which I believe at CMAR, they are able to get medications at a discounted price, which is then passed on to the patient. And that's all I had, unless anyone had any questions.
Thank you so much for that great summary of just resources and tools for increasing access for our patients for these needed medications. And I think all of us know that they take a little bit more effort sometimes to do, but it's well worth it. And that's why we're here to be advocates for our patients. So thank you. And thanks so much for that review. Carol, do you want to also update us? I know, we've talked about GLP-1s in the past and access with our Medicaid formulary, but I know before you start the case, you've actually had some great success prescribing Mounjaro, our new GIP GLP, even in our Medicaid and at your free clinic. So tell us a little bit about that, because that's the new kid on the block.
I have had good success. It always requires prior authorization and sometimes even an appeal or doing a peer-to-peer with somebody at the whoever the approval place. The things I use for Mounjaro, well, for any of the GLP-1 RAs and Mounjaro, is that I often will tell people that for compliance reasons, they need a once weekly dosing, that they're much more compliant with that. That seems to fly pretty well, especially if they have depression or if they have multiple medications. I use that as a justification for needing once weekly. The Mounjaro is a little bit more efficacious, and I've used that when people have not met their goal on the GLP-1s at the maximum dose. Obviously, we're really excited about the weight loss, but that weight loss isn't covered by any of the insurances. So using that as a reason just doesn't fly, because it means nothing. So yeah, it's mostly once weekly and efficacy that I've worked with.
Thank you for sharing that, both for the GLP-1s and for the GLP, just because, again, we're trying to do is share our successes so that other people have the opportunity to use what we've learned to empower our patients and get them the medications they need. So without further ado, I'm going to ask Jessica to share her screen. And Carol, go ahead and tell us about this interesting case that you are going to present for us today.
Okay, this patient is a 51-year-old male who is uninsured, who came to me following his discharge. I saw him last April, but he's an interesting case, so that's why I'm presenting him. My concern was with treating him was that he's overwhelmed with all his medical stuff that he's doing, and since he has no insurance, how do we maximize his control? So he presented in April to a walk-in clinic complaining of a sore toe. So that's his toe at presentation. His A1C was 11.6. His blood sugar was 430 something or 450 something. And he had a history of diabetes. He had been diagnosed 4 years earlier with an A1C of 10.6. And he had been treated with metformin and some glimepiride, but had not been seen for 3 years up until this April. And he had stopped his medications. So he was admitted to the hospital. His toe was amputated. The pathology showed residual osteo at the site of amputation. At that time, he was on ceftriaxone, which he was getting at the outpatient IV infusion center daily. So he had to go into the hospital daily for this, which was he was terribly overwhelmed by that. He was on metformin, 1,000 milligrams BID, but he hadn't picked up his metformin yet. He was on glargine, 35 units a day. And he was on Lispro 5 units before meals with a sliding scale. He was taking his blood sugars sometimes, and he said his blood sugars were around 100, in the hundreds, but he didn't bring his readings in, and so I had no verification of that. He's allergic to amoxicillin. His family history. Can we go back up to his past medical history? Because I didn't go through that, which is important for him. He has a past medical history of depression. He's been depressed since he was 17. His parents separated when they were and divorced when he was 12. He has a history of being bullied. He has tried in the past his 3 different medications: buspirone, bupropion, and escitalopram at 30 milligrams. And he said none of them helped at all. And he didn't feel counseling helped. He had a history of hypertension, and he had a transient episode of atrial fibrillation while hospitalized, which he had a Zio patch on for to evaluate the burden of that. Okay, let's go back down to where we were. Okay, his family history. His mother has a history of depression, and she's currently on sertraline. The other is listed there. In terms of his social history, he has no history of alcohol, drug use, or tobacco. He's married for the 3rd time. He's contracted data entry personnel. He graduated high school. You have his vital signs and his BMI there. On physical exam, there was really nothing outstanding except that his wound was healing on his toe. And you have his current lab values that I had. Those were on presentation. I had his creatinine was normal. I have no lipid profile on file for him. And okay, so when I first saw him, his PHQ-9 was 23 and his GAD-7 was 21. He complained a lot about just all the stuff he had to do, watching his diet, doing his finger sticks, doing his insulin, going to the hospital for his antibiotics. These are just his total labs. Really, the main thing that sticks out is his glucose. And what have I forgotten? So he came to me, and my job was to maximize his insulin control, his blood sugar control. Oh, he's had very little. He had some diabetes, self-management, and nutrition therapy in the hospital. It wasn't clear how much, and he had one session 4 years ago with this educator. And let's see what else. Oh, this was, I put a Libre sensor on him. When I first saw him, I had him come back 3 days later. And this was 1 day's worth of dietary log. And he gets his antibiotics in the morning about 10:30. And do we have the Libre graphs? So there's 3 days worth of the Libre sensor of what he'd taken. Obviously, he's not scanning all the time. And then his pattern for that time period. And so that's what I had.
Thank you so much, Carol. What a great discussion. I'm going to let Lorena go ahead and talk about some details of the case now. Go ahead, Lorena.
Yeah, thank you. Yeah, great case. So challenging, right? Because mental health and so on. So a recap, this is a 51-year-old with type 2 diabetes diagnosed in 2018, as far as we know. He probably had diabetes for a longer time. Overweight with a BMI of 28, history of osteomyelitis, status post-right grade 2 amputation in April, on daily IV antibiotics, and needs to do daily trips to the emergency department. And comorbidities include hypertension, paroxysmal atrial fibrillation, and depression. So he's married and insured, and we heard, about mental health, the issues, and feeling overwhelmed. So as usual, right, we always ask, this person produce insulin? Could this patient be type 1 or type 2? Is he insulinopenic or insulin resistant? And I think we all agree that he is insulin resistant. And by looking at the labs, even with a blood sugar of 453, right, carbon dioxide was normal. There was not an anion gap, so not even a mild DKA. So he is producing insulin, and he seems to be very insulin resistant. Okay, and the second question is, what is his A1C goal? So he is overwhelmed. However, he definitely needs better control because of what is going on with his osteo. So I would be very happy if his A1C decreases by 2% every 3 months, right? So if it was 11, when I come see him back, it's 9, I would be happy. And perhaps I would be, the lower, the better, of course. But then once he is more established and perhaps less overwhelmed, I tend to think that as long as the patients do not have hypoglycemia, the lower they can go, right? Like the limiting factor, it is hypoglycemia in my mind. Okay, yeah, so then moving on, what are we going to do, right? What are we going to do for diabetes? And I think that treating depression is really important. They don't really have the drive. They will be, not really testing blood sugars very often. So I would ask Paul, what recommendations you have.
Sure, Lorena, thank you. And thank you, Carol, for presenting this case. Your instincts were fine. Carol, you had recognized that he'd failed some medications in the past. And at the time that you saw him, he had these sky-high PHQ-9, which assesses depression, and G87, which assesses anxiety. He has a long history since 17 years of age. The question, though, is, at what point does he need something to help him because of what Lorena just mentioned? And someone with ongoing depression and anxiety is going to have poorer healing, higher blood sugars, poorer adherence, and poorer engagement. So medications may be a longer term strategy, but in the immediate term, certainly this is a crisis. So he needs to bolster coping strategies, and that can be done with somebody that maybe Ludmila can talk about later, about available resources for someone with no insurance, which was the case when this person first presented. In that community, who can provide that kind of care. For example, it could be a care manager, a telephonic or Zoom-based care manager for 3 to 6 sessions, just to help him with coping strategies. And then a medication can be considered. I will say, when we did studies of over 4,000 patients at Group Health Cooperative, which is now Kaiser, in primary care, we found that 2/3 of people with diabetes, there were 4,000 people with diabetes, mostly type 2. We found that 2/3 of them that had depression had what we call double depression. In other words, they have a major depressive episode, but they also have what's called persistent depressive disorder, which we used to call dysthymia. So that means that their baseline is that they are going to never be without some low level of depression unless they get significant treatment. And so this person may very well have had what we call dysthymia, which is their baseline, which means that they've had depression more days than not for at least 2 years. That's the definition. But this person also has significant anxiety, highest G80 score possible, 21, again, in the context of a crisis. So again, the real go-to strategy here would be to bolster his coping strategies, determine what's going on. We don't know also if he's drinking or how he's coping. Is he using some negative coping strategies that are propagating things? So I'll stop there in the interest of time, other than to say, as far as a prior trial, he was on bupropion. I don't know the dosage there. He was on a higher dose of escitalopram, which is Lexapro, but buspirone is an anti-anxiety agent. So he's really only been on 2. It's worth another try, maybe an SNRI, which such as venlafaxine, duloxetine, especially and he's probably not far enough along to have a diabetic neuropathy, but those medications can also help with that. I'll stop there and see if Lorena or Carol, you have any other clarifying questions.
I do have another concern that was kind of going through my mind.
Sure.
His having failed, although he was only on one SSRI, I had documentation that he had taken a good dose for a while and didn't help him. And one of the things I always wonder about in people who fail SSRIs is whether they could be bipolar and we're just treating the wrong kind of depression. I didn't have any history of his worsening with the SSRI, but that made me, the fact that he might worsen if I tried another SSRI if his diagnosis was bipolar, made me also reluctant to try to start something at the time I saw him. And again, those are judgment calls.
Yeah, no, a very good concern. And we always want to rule out periods of mania or hypomania in anyone we're starting an antidepressant on. And there are many reasons for people to fail their antidepressants, but bipolar, having mania or hypomania, or actually having bipolarness could be one reason. Absolutely.
Thank you so much, Paul, for those insights. And I think you're just really highlighting, when we're talking about cardiometabolic disease and chronic disease in general, how important mental health is and how much it is such a component of it. Before Lorena goes on, I think Ludmila our social worker, was going to sort of just comment on those resources available in the community for depression, and maybe specifically to CMAR, which is a lot of our participants, what we can utilize in those uninsured populations for depression help and support.
Yeah, so CMAR does offer support. So what the patient has to do is speak to one of the customer service reps. They have to bring with them like a proof of income. If they are unemployed, they just have to bring in documentation about how they are financially paying for their bills. And through all this documentation, the service rep will support the patient in applying for a financial assistance program. And with that, then they can be eligible for mental health services or any specific needs that they meet. And so that's through CMAR. We also have a support group that I did think about that CMAR has. It's a diabetes prevention program. And so they can have one-on-one appointments with the patient. There's groups that they have and community-based classes that they can access. They just have to go online and apply for those. And there's different forms they do have to fill out. I also found some support groups that could be helpful with mental health. NAMI Seattle, you could just go on their website. And it doesn't cost to attend, but there are support groups that can help individuals with anxiety, depression, any kind of mental health diagnosis that they're experiencing. There's also another support in the community. It's called 7 Cups of Tea. It really has a support group for anxiety, depression, any of those barriers that they're facing due to their diagnosis. And there's another one called Health Unlocked. It's a community safe space, and it's for individuals who are impacted with anxiety and depression. And it's a community-based group where people can go and kind of talk about prevention, treatment, and ways that they can overcome what they're experiencing.
Thank you. Go ahead, Lorena.
Thank you. Those are great resources and great points about mental health. A lot of useful pearls. And here we have, 3 days of CGM. So very erratic control. So you can see that the first day, fasting blood sugar is kind of like in the 200s. Then it's a little better the next days, but then he has a huge spike followed by hypoglycemia really, really quick. So when I see things like this, what I suspect is that the patient is probably given insulin after eating. So he is, eating, blood sugar goes up quite a bit. And then this is probably where he is given his insulin because, then it drops really, really fast. So then when I see something like this and I ask about how they are using their insulin. So what would you do, when your blood sugar is normal? Do you give insulin? And I just ask a lot of questions, looking at the graphs to try to understand what happened. So he drops very, very abruptly, and then it's followed by a overcorrection, and then there he goes, and this is kind of like a roller coaster. Other than understanding really well how the patient is using his insulin, I also talk about the hypoglycemia when patients are on CGM. We teach them the rule of 15, that eat 15 grams of carbohydrates, and I give some examples of what things have 15 grams of carbohydrates, and then check again in 15 minutes, and if you're still low, then go ahead and do another 15 grams of carbs. I do tell them when they are on CGM and they are new to be aware of what we call pressure lows. Sometimes at night when the patients are sleeping in their, sleeping on top of the sensor and they're pushing on the sensor, then the sensor might read as low, but they might not necessarily be low. So especially so that I ask them whether they had symptoms with that low. And sometimes they say, no, I was actually surprised that, it said that I was 50, but I was feeling okay. So when that's the case, I ask them to check with a finger stick or to just, if they were actually pushing on the sensor, to stop that and see, if they are not symptomatic, to wait to see what happens. Because a lot of times they are actually not low, but they go ahead and correct. And then what follows is like, blood sugar of 300. I also remind them that the CGM, the reading that they are seeing right now is delayed. So then once they correct the hypoglycemia, the symptoms go away, the sensor will still be telling them that they are low. And sometimes they just keep correcting, right? And they might say, and it wasn't coming up. Like I kept, having carbs and it was still low. So, but then, and I had a blood sugar of 400. And that's because, they kept having carbs and correcting, but they were not low anymore. So they were misled by the delay, reading in the sensor. And I also tell them that in the low end or the low range, all sensors tend to be less accurate. So sometimes the sensor might tell them you're 40, and they might not be 40, right? Like they might be 65. So what I tell them is, but you are close, right? Like, so then if you are symptomatic, then treat, but you might not necessarily be that low. Sometimes the sensor might say you are 70, but they are 90, because in that low range, it's a little less accurate. So then when in doubt, do a finger stick, and that will prevent some overcorrections of hypoglycemia. The other thing that could be happening is when we look at the fasting blood sugars, we really need to understand what is happening before dinner and at bedtime. Sometimes what happens is that they start with a, okay blood sugar, but then they're not using their prandial insulin, or it's not enough. And then blood sugar goes up with one meal, then it goes up again with the next meal. And then, by the end of the day, their blood sugar is really, really high. And then overnight it corrects once they stop eating. And so then I would be interested in knowing really what happened before. If the patient is not scanning, right, like there are like gaps in the CGM, then probably they are really not given insulin then, right? Like because they are new to the sensor, and then he is depressed and he is overwhelmed. So he might, when he didn't scan, likely, so here it looks like there is a gap. He probably didn't scan here. Maybe he didn't give insulin with dinner, and then his blood sugar is kind of okay, like in the morning, because perhaps the dose of basal is kind of high. So then that could then cause this big drop, right? Like then even if he gives then his insulin before eating, because he has a lot of background insulin, and he goes down pretty quickly. So then so that's, that's kind of like to give you a visual of, what happens. Then sometimes the fasting blood sugar can be a little bit misleading, and we really need to understand what's happening the night before. So the patients sometimes might be skipping insulin doses, or they might be injecting it at the wrong time, only when glucose is high. So in him, I would then worry that because he is kind of crashing, right, like then he would then be very afraid of giving insulin, like the short acting insulin, because then he associates the hypoglycemia with the short acting, but it might be the long acting, the issue. When they are not on CGM, when they are on finger sticks, self-monitoring of blood glucose, I recommend to test, especially when they are, depressed or overwhelmed. I only want them to test their blood sugars when they are going to act upon the results. So then, if they are on prandial insulin, checking the blood sugars before eating, so then that can guide the dose. But then I might not, want them to be testing after eating, or because they won't be able to do anything then, and then I want to use, the finger sticks in a very productive way. Another thing to consider is, because Carl, you mentioned that he would have his infusions kind of like in the morning, right? Like some antibiotics might increase the risk of hypoglycemia. The most notable ones are the fluoxetine, levofloxacin. They do, increase the risk of hypoglycemia significantly. He is on ceftriaxone. Yeah, so that's not necessarily one that is strong associated with hypoglycemia, but in patients on antibiotics, this is always a good to remember. So when I have patients who are overwhelmed, I refer them to Paul. But I do praise their success, even if it's small. So I would say, wow, you are doing your insulin, and you are, every little single thing that they are doing, I would praise a lot. And I would talk about the immediate benefits of glucose control. I would say that it is really important for wound healing and better immune response. So then you fight this infection in a more efficacious way. And then I, think of how can I make this regimen less hard, because it is really hard, to be on insulin so many times a day. And I also prioritize the interventions. So obviously, with this patient, there are so many things that we want to do, right? Like we want to add a statin and, all these things, but then he is overwhelmed. So that I'm going to not do a lot of things at once. Carl, which I think you did that was, very important. So I kind of focus on what will be the most beneficial right now. And then I remind my patients there is a team, we all want to help you, and you are not alone on this. So I want to know then, right? Like I want to calculate his insulin doses. Currently, he's 97 kilos, BMI is 28. So the current total daily dose, not including the correction, it is 35 basal plus 15 units of prandial, assuming he is having 3 meals and giving the insulin 3 times a day. That's 50 units. That's 0.5 units per kilogram. That seems very reasonable for a patient with type 2 diabetes with insulin resistance. The sensitivity and correction, this is the formula, right? Like you have this formula that has been given to you before. So we divide this by the total daily dose of insulin, and that is the correction. So he is currently, his insulin is currently distributed at 70% basal and 30% prandial. So in this patient who is overwhelmed, then I would consider changing to mixed insulin 70-30. Because he's already in that ratio, then I would just then give half and half. So then I would, very important, right? Like, so then we want, I will come back to the insulin, but also very important is that we always have to think of the patients who have cardiovascular disease. And he does, right? He very likely has peripheral vascular disease, atrial fibrillation.
Dr. Brandt, good comment on his relative cardiovascular risk, especially given the fact that he has this osteomyelitis, had this transient AFib, and obviously has uncontrolled diabetes and hypertension and elevated cholesterol. Go ahead.
Thanks for having me. I think it should just be noted that anytime you run into a patient with peripheral arterial disease, these are the highest risk cardiovascular patients we run into, save those of very low ejection fractions, heart failure, cardiogenic shock, that kind of thing. From an atherosclerotic standpoint, once you get enough burden of atherosclerosis that you are manifesting peripheral arterial disease, because you can imagine these are big vessels as compared to coronaries, and especially lower extremity atherosclerotic disease, your risk goes up substantially. And if you take these patients, you compare, all of the risk factors, you even put in diabetes, you put in age, you put in, hyperlipidemia, et cetera, your risk of mortality with PAD doubles. Your risk of major adverse cardiovascular event is up 4 times that. Your risk of amputation is over twice. So, these are very, very high risk patients. And specifically for this patient, they've already had their amputation. Once you have an amputation, your risk of having a subsequent amputation in the next year doubles. It can be as high as 4 times. And then your risk for major adverse cardiovascular events can be as high as 12 times, especially with uncontrolled diabetes. So this is an exceedingly high risk patient for cardiovascular disease. Control of his diabetes becomes important. Looking at all the other aspects of cardiovascular risk is also critically important. Yes, he needs antiplatelets. He probably should be considered strongly for dual pathway inhibition with low-dose rivaroxaban. If he was not, guess what? In atrial fibrillation. So now he has to have anticoagulation on board, but you should be thinking about anticoagulation, maybe an antiplatelet, probably something like clopidogrel or ticagrelor, not aspirin necessarily, but at least 2 medications. So very high risk, needs to be aggressively treated. Yes, diabetes, but really looking at everything else becomes critically important for him.
And great points, Kelly. And I think this is going to be a time where, Carol is going to pick and choose, and the focus right now will be first diabetes control, and then over time we're going to be cutting back all those other cardiovascular risks. So a great addition to the discussion there.
I'm just setting you up for this one right here. Tell us all about GLP-1s and SGLT2s. Go.
Yeah,
this is aggressive treatment.
Go ahead, Lorena.
Yes, so very important, right? So then I would add Victoza, right, because of coverage, and it is a great medication. So, but again, the patient is overwhelmed. So with blood sugars in the 400s, right, like an osteo, then I would focus on glycemic control first, not to overwhelm the patient. I probably wouldn't start Victoza right now. I would discuss with the patient both options, the option of mixed insulin, right? And then, or continuing basal bolus, ensuring the dosing, he's dosing the right way. If he was to choose, I can continue the basal bolus. If he chose that option, then what I would do, I would reduce the glargine, right? Like 50% of the total daily dose is 25 units. Given that he also have been having these drops on the hypoglycemia, and I don't want him to get scared, afraid of insulin and not, using it. So then I would emphasize that we are going to reduce your glargine. So he feels more comfortable. And I would say, do you feel comfortable with 25, or did you prefer 20? And then, so to negotiate the doses, and I would reduce the prandial insulin a little bit, or like 40 units before meals. And that is, I think he might probably need more, but I just want him to see that I am reducing the insulin, right? Like making sure that he's doing it correctly before eating. And then I wouldn't change the correction, even if, when I calculated the insulin sensitivity, it would be a little more aggressive. But again, right now, I just want him to not be scared of hypoglycemia, control his blood sugars. I did say aspirin, right? But then you heard the expert, Dr. Branch. So then thank you for that. And then, at the following visits, then I would add an insulin sparing. I would probably add Victoza at the next visit. And then, future visits, and we have a lot, of things that we can do for him. So I will definitely add a statin, LT2 inhibitor, and using all of those wonderful resources that we heard about.
Great comments, Lorena. And I think what you saw was that we were addressing the diabetes and also trying to mitigate some of his cardiovascular And then, over time, as he's less overwhelmed, discussing the benefit of all these additional preventative medications. So great points. And then hopefully we can figure out a way to help him get insurance so that we then can advocate for a weekly GLP-1 or something else to further improve his ability and decrease his burden for injections. The final thing I wanted to point out is that I love how you reduced his insulin, because you can always go back up on the insulin if he's only having high blood sugars, but one low blood sugar will keep someone from taking the insulin. And as well, especially since you're going to start the liraglutide, you really do want to do a decrease of dosing of the insulin, even in those people that are having high A1Cs or high blood sugars, because sometimes people have a very strong response to it and you're not sure about the barriers to taking that full dose of insulin all the time. So I love your technique, which is to reduce, make the person comfortable, and then add on the GLP-1, and if he really only needs 4 to 5 units of prandial insulin, the hope would be is maybe he'd come off the prandial insulin and significantly reduce his dose of the basal or background insulin as you escalate the dose of the liraglutide. So great point. And
Nicole, can I make one quick one here? Because I think it's important as we're talking about these medications. One of the misnomers that's out there is the use of T2s, specifically in these patients with peripheral arterial disease, and this risk of increased amputation that they saw in something called the Canvas trial with canagliflozin. And you see these kind of black box warnings. All the subsequent studies for any other SGLT2s, for the GLP-1s, really for any of these, including a large 2 million patient registry that came out of the United States, showed that was actually just bogus. It just has not come to fruition that we see increased amputations either with SGLT2s or GLP-1. So you're going to see this lower because of one phase 3 trial, but really real world analysis and all subsequent analysis have been neutral.
Thank you very much for highlighting that point, because one of the barriers always of starting medications for patients is a perception of a risk that maybe that needs to be more fully discussed. So such a complex case, so much we can do for this patient. And I just want to say thank you for participating in session 14 of the Cardiometabolic Echo. And this ends session 14. Thank you.